All right, welcome everyone. Thanks for coming today. We have a great speaker we can look forward to. This is actually a couple different components came all into this one talk, and I'll talk about them all briefly. So this is the first discussion session for ORALM 651, which is health and homelessness. It's a class started in the dental school that is open to all students, and there's still space available if you want to register or need to register still. And so that class is composed of some discussion sessions like today, and then also some outreach. The outreach is a really important component so that, the stuff we learn here we can apply out in the clinic or out on the streets or out wherever you're interacting with homeless individuals. So I'm just going to start for the people who are newly registered for the course or who are registered. Just the objectives for the rest of the spring quarter. So we're going to talk about, what kind of social, cultural, legal, and political factors contribute to homelessness in Seattle. And if you took the course last quarter, we kind of started talking about that, and we'll continue that this quarter. Understand, what gets in the way of people finding shelter for homeless individuals, and what keeps them, once they find shelter, can they keep shelter? What are the oral and systemic health issues that homeless individuals in Seattle are confronted with? And today we'll kind of hear about Vancouver, the Downtown Eastside of Vancouver. Understand the healthcare access problems for homeless. Can they find clinics? Can they pay for clinics? How are they able to get to clinics? And then the outreach experience for this quarter will be 6 hours. So there'll be some outreach that'll be set up by the class. There'll be some from the dental school that is already set up, and you can kind of coordinate with your departments or partake in the outreach that's planned for the course. And then, how can us, it looks like there's people from nursing, medicine, dentistry, I don't know, what else? How can we work together to address issues of homelessness and, better serve their health needs? So as I said, there will be 5 discussion sessions for this quarter. 1 hour sessions just like today. Usually there's lunch, but there isn't today. I apologize. And then volunteer activities. This can be, one really long outreach of 6 hours, or you can divide it up throughout the quarter and participate in different kinds of activities and interact with different neighborhoods within Seattle and see kind of how each neighborhood is affected. So the schedule for this quarter will start today with Darwin Fisher. He'll talk about substance abuse and harm reduction. And then the next 4 sessions are listed up there. We'll have speakers from the School of Medicine, speaker from the program at the the VA hospital, started a homeless project there just recently, recent graduate, and then end the year on domestic violence and homelessness from 45th Street Clinic. So these are some of the outreach activities you can participate in. We have most of these are from the dental school. I apologize if you're not from the dental school and these don't apply, but we're always welcome to take in people from other departments, and they can kind of participate with these as well. So we have Roots Young Adult Shelter, which is in the U District. Teeth and Toes, which is kind of at various locations, has been at Hammond House, has been at others. Century DeVita is an outreach opportunity in Tacoma. 45th Street Clinic, House of Mercy, and then the Union Gospel Mission Dental Clinic, which is actually a brand new thing. It was actually on the horizon thing last quarter. So it started, and patients have been treated, and if you're a 3rd or 4th year dental student, you can actually treat patients there. So one more plug, and then we'll let Darwin speak, but it's interesting that we brought a speaker in from Vancouver when our next common book, I don't know if anyone participated in the common book last year, but the common book for next year is In the Realm of Hungry Ghosts by Gabor Mate, and he is a doctor that practices in the Downtown Eastside in the clinic. And it kind of recounts some stories of his experiences, and I'm, not all the way through it. But it's a great book so far, so I'd recommend, get it now, but there will be a lot of discussion sessions next year around the common book, specifically for the common book. Last year there were 4 sessions hosted by 8 schools, and, they each took a different aspect of the book, the common book last year, and, discussed it in a group. So hopefully you guys can pick this up. And also, if everyone could sign in and fill out evaluation sheets before you leave, that'd be great. So without further ado, I'll introduce Darwin Fisher, who is from Insite, which is a supervised injection site in Vancouver's Downtown Eastside.
Thank you. Should I just hold this? Does it work?
Strap this around.
Strap this around my neck or something. Whatever. I'll just hold this. Can you guys hear me? Great. Hey, thanks for having me down here. It's actually super cool to be in Seattle, which is so much larger than Vancouver. I can't believe it. Vancouver, how many of you have been to Vancouver? Hands up. Lots of you have been to Vancouver, probably on your way to Whistler. It's not a big city on the scale of Seattle by any means. It's a medium-sized city with a hell of a lot of suburb around it. And let's see if I can move forward here. Nope, did that work? That didn't fucking work. There we go. So Insite is located. Insite is a supervised injection clinic in downtown Vancouver. In fact, it's in the Downtown Eastside of Vancouver, which is Canada's poorest neighborhood. Very densely populated and very small neighborhood right in the heart of Vancouver. And this place the Downtown Eastside was not always a low-income area. In fact, if we were to go back 100 years to 1913, the Downtown Eastside, that small stretch of blocks that is now the poorest area in Canada, was actually the center of downtown Vancouver. And in the block that holds Insite, if you look across the street, there's a tall building that was originally Vancouver's City Hall. If you go up the street a bit, you will see a building that used to house Vancouver's first stock exchange. The main public library is very, very close to that. So in 1913, this was the center of culture and commerce, and in and around the City Hall and the Stock Exchange and the library, there were many, many, many hotels in the area. And these hotels were primarily catering to sort of the carriage trade. People would live in them. They were reasonably luxurious accommodations, or a variety of accommodations, and they were more sort of sustainable and had amenities and things like that. But what happens as Vancouver evolves through the 20th century, rather than things like the City Hall and that being clustered around the port, we have major roadways like all cities, and they start to attach themselves to things like Broadway and main streets and things like that. So our City Hall moves away, our library moves away, our financial district moves away, the entire downtown moves out of that area after the Second World War. And what happens to this area? Well, what happens is that every single hotel in that area, and there are many, many, many of them, get gutted and they get reconfigured into what we call SROs. Do you know what SRO stands for? Well, two things, single room occupancy or standing room only, and it's kind of the same thing if you've ever been in one. Have you ever been in an SRO, anybody? Very, very basic accommodations. I can tell you in Vancouver, most of the SROs that I go into and see, they are smaller than that alcove for sure. And what you get in an SRO room is you get 4 walls, a sink, a bed, and if you're lucky, a window, right? Who would use this? Who would stay in this? Originally, this housing was catering to a seasonal workforce that would come into the area and work in related industries around that area. The cannery industry, longshoring industry, people who were sometimes laid off for periods from the lumber industry. There were all sorts of thriving industries around there, and the accommodations were available short-term, maybe for a few months. And if you're coming from a rural area and you're coming to the city and you want to make some money and you don't want to spend some money, an SRO is a decent alternative that way, or it was at that time, right? You don't have any amenities in your room. You eat in a restaurant, you get a shave in the barber shop, you drink in the beer parlor, and all of these places had liquor licenses at the bottom. Now, this fantastic picture on half of it, the screen there with the cabaret sign, is actually the block that Insite is now on. And this picture is from 1958. If you guys ever want to look at some amazing pictures of Vancouver, Google Fred Herzog. He's a photographer that took color pictures of Vancouver through the 50s and 60s. At this point in time, Vancouver, I kid you not, had the highest amount of neon per capita in North America. Not very hard to believe from that picture there. Now, the street looks a little bit different, but anyways, this is a snapshot of Vancouver in the post-war era. And it was functional as a community where seasonal workers would be living in these hotels, maybe into the 1960s. And the picture on the other side there is of the Empress, and that's a very typical looking SRO hotel. Most of these places aren't just rooming houses, they house maybe 80 to 100 people, so they're large buildings. Now, what happens as we move into the 1970s is that a lot of these seasonal industries start to contract, and by the 70s, they're really drying up. And more, this housing in the Downtown Eastside is becoming the full-time, year-round housing for people on fixed incomes, pensioners, people on disability, people on welfare. And in terms of being full-time housing, it's actually really insufficient. An SRO is an okay place to stay in for a couple months or a month. It's not a great place to spend the rest of your life in. So by the time we're into the 1970s, it really has an identity as the full-time, low-income neighborhood for Vancouver. And what happens there is a sort of a civic planning problem where it becomes less and less affordable for people on fixed incomes to live anywhere else in Vancouver. Now, right now, I don't know what the shelter allotment is for welfare in Seattle or Washington, but in British Columbia, it is $375 per month. You go on Craigslist and you look at what a one-bedroom goes for, and the entry price is generally around $800 to $900. So more and more that disparity starts to happen in the 1970s, where it is unaffordable for people to live anywhere other than these SROs in many cases. And what happens as we're getting into the 1980s is it gathers a lot of advocacy around that. It's recognized, it gets its name now, the Downtown Eastside. It's recognized as a low-income area, and it gets a lot of advocates in the area. Names like Jim Green and Bruce Erickson, they're advocating for better living conditions and the building of social housing and services in the area that are relevant to low-income people. So that activism starts in the 1970s because what's happening is that housing stock is eroding. There's not a lot of money in renovating it. So it's becoming more and more decrepit through, I'll just flip that slide, more and more decrepit as we move into the 70s and 80s. As well, what's happening is that we start losing the housing stock, and it's not being replaced by social housing at the same rate. We had something in 86, which I think you guys had something similar in 62. We called it Expo 86. Let's show off Vancouver to the world. It was a really big deal. We're such a provincial town in a way that we really wanted to show ourselves off, and we did. And it's like a big trade fair, and what the big trade fair is selling is it's selling real estate, essentially. And real estate prices in Vancouver after Expo went apeshit. And that discrepancy in terms of what is rentable, there's less rentable stock, the prices for rentals go up, and it gets less and less possible for people to negotiate their way out of the Downtown Eastside or to live anywhere else. So there's a bit of a housing crisis on the margins there. And what's also happening is a lot of SRO hotels were torn down to make way for Expo projects. And that gentrification and that heated up real estate market means that more and more of these buildings are being either repurposed or torn down. So you have this crappy housing stock that's not sufficient, and there's not enough of it. It's like a Woody Allen joke in a way. And then what happens is as we're losing this housing stock, which is more decrepit, we are gaining substantially in population in the late 1980s. And we're gaining it from some very vulnerable populations. First Nations people leaving the blight of reserves, coming to the city for the same reasons I came to the city, same reason you probably came to the city, which is community, prosperity, things like that, and generally not finding it. First Nations people became more and more overrepresented in the Downtown Eastside. Now, First Nations folks are 2 to 4% of the Canadian national population. I believe, I should look this up again, but I believe they're about 14% of the Downtown Eastside population. That is overrepresentation. And even more serious in terms of its vulnerability was the decision by the Provincial Health Ministry to downsize our largest congregate care mental health facilities in the late 80s. And they released thousands of mental health consumers into the community. Now, living in the community, if you're a mental health consumer, is great and in many ways preferable to living in a congregate care facility that's off to the wayside, you know, with all those images of the snake pit. The community has a lot more to offer, but there were no really adequate supports set up for these folks in the community in terms of housing, access to social services, medical care, things like that. So you have an incredibly vulnerable population that generally tends to be congregating in the Downtown Eastside because of budget issues, all kinds of issues, and this is a super vulnerable population. So we have an increasing vulnerable population, we have decreasing and declining housing stock. And this is sort of one aspect of a perfect storm that sort of comes around Vancouver in the late 1980s, and this becomes more and more noticeable. Now the Downtown Eastside has been a low-income area for about close to 70 years. Historically, it has substance abuse in the area, primarily centered around alcohol. So there's a history of substance misuse around there. There's also been some opiate use in the area throughout the century. The first methadone program in North America started in the 1950s in Vancouver, centered around the Downtown Eastside and heroin use. So it has a history there, but nothing that's really profiling until we start getting into the late 1980s and around the curve of the 1990s. Now, low-income areas, traditionally in any city, when you have ineradicable illicit activity, the police department, the powers that be in general, are going to tend to funnel that into low-income areas. I mean, let's find a place that's right in downtown Vancouver, outside of Nordstrom's, and let's deal some drugs there. I bet you we will get some attention really, really quickly on that. Whereas if you do something like that in a low-income area, generally you're getting less calls around that. So either implicitly or explicitly, a lot of the illicit activity in Vancouver gets funneled into the Downtown Eastside, so you have an established illicit market. And you have a housing crisis, and you have a vulnerable population. And more as we get to the late 1980s, we are seeing visible homelessness in that condensed area, and visible homelessness of some very traumatized individuals. Because if you think about it, it's a tight housing market, and I'm the guy with behavioral issues or mental health issues, and maybe I don't communicate very well, or maybe I seem really cranked, or maybe people are a little bit afraid of me, things like that. Chances are I'm going to be the first person to lose my housing in a tight market. So more and more visible homelessness, established illicit activity. We are near a port, and it seems like around 89 or 1990, this just explodes, you guys. And we start seeing an amazing amount of injection drug use in the Downtown Eastside, more and more of it as the 90s turn around. And what is really reading in terms of the powers that be in the general population is what they euphemistically call public disorder. Right? We are seeing more and more visible homelessness, visible chaos, and sometimes visible addiction on the streets. But that's the extent of what's known, and what really starts to bring the problem to light is when the chief coroner for Vancouver starts looking over the death stats. And by 1992, it was apparent that those death stats were doing something really unusual. So I'm not keeping track with my slides here. Jesus. Yeah, been through that. That's a nice example on top of some of the decrepit state of many of the SROs. And again, visible homelessness coming on like that. And again, a very vulnerable population. So again, the area gets flooded around 1990 with cheap, potent, and very plentiful heroin and cocaine. And heroin injection has a bit of history, but what we're seeing more and more is injection cocaine in the area as the 90s turn. What we occasionally see at Insite is that people are even injecting rock cocaine. Why would people inject rock cocaine? It's made to be smoked. Any thoughts? No, I don't have any thoughts. Well, I asked somebody, which is a good thing to do when you don't have thoughts around it, why are you injecting raw cocaine? And they sort of explained it to me. If I have been binning all morning to get $5, that's all I make after a morning of binning, and I need to get well, I need to get unsick, and all I can afford is a $5 piece of rock. If I go and smoke this in a pipe, what's going to happen? I'm actually not going to get all $5 worth. I'm going to be losing some. It's going to get, leak out the pipe. It's going to get stuck in the filter. I'll lose some to the walls of the pipe. I will try and do everything I can to maximize how much I get off of that $5 rock, but I'm not getting all of it. Whereas if I choose the riskiest form of ingestion, which is injection, I'm going to break this down with some vitamin C powder or some vinegar. I'm going to draw it up in a syringe. I'm going to inject it directly into my bloodstream. I am getting 100% of it. So a lot of the crisis around injection drug use in particular, why people were choosing the riskiest format, were also for reasons of economics as we get into the 1990s and an incredibly poor population. So what we began seeing is overdose death stats on the rise. Now in 1988, province-wide in British Columbia, there were 38 deaths due to illicit drug overdose, and that is a very standard, that's not an unusual amount. So 1988, 38 deaths. By the time province-wide, these are civic stats, but by the time province-wide we were into the early 90s, those deaths were in the mid-200s per year. And by the time we got to 1997, overdose death rates were 412 that year. So from 38 to 412 in the space of 9 years. It was, in fact, one of the leading causes of death for males aged 30 to 49 in that year. Now, those are provincial stats. These are Vancouver stats, but it was very apparent that something drastic was going on in the Downtown Eastside. That was the epicenter of what was going on here. So, not only are overdose death rates going up, but there's a sense from the amount of what we know about people using drugs intravenously, well, that our needle exchange policies around 1990, circa 1992, were not keeping pace with this new development. Vancouver's needle exchange policies, I don't know what they look like here, but in Vancouver in the early 90s, they were a total of 3 needles per day. And to access those 3 needles, you had to bring 3 dirty needles. That was a 1-for-1 exchange. And the hours for needle exchanges were quite brief. They were more like banker's hours. And this turned out to be a disastrous policy because, I mean, there's a lot of injection going on, period, but when there's an epidemic of cocaine injection, cocaine is a very short half-life. You need to re-inject. If you're severely addicted, you may be injecting 12 times a day. It's not uncommon. That means that people are reusing and sharing needles like crazy. That means that needles in, after hours, let's say 1 o'clock in the morning in 1992, it means you pay $5 for that. And I can't tell you how much $5 is in the Downtown Eastside. You can buy a bike for $5. You can buy all kinds of things for $5. People were not often spending that on rigs. So lack of adequate supplies due to some benighted policies on part of the healthcare authority in Vancouver made people think that we were probably going to be seeing a rise in HIV rates. So what happened is our Centre for Disease Control, the BC Centre for Excellence in HIV and AIDS, actually came down to the Downtown Eastside in the mid-1990s and began doing some comprehensive surveying and information gathering. And this is incredibly important to actually find out stats, because where you don't have cold information, where you actually haven't gone out and mapped the terrain, ideology will rush in to fill that. And a bunch of suppositions that you have in the back of your head will rush in to fill that void. So it's really important to gather information. And the VITA survey, as it became known, the Vancouver Intravenous Drug Users Survey, surveyed 1,000 users in the Downtown Eastside. And it kept surveying them. It would interview them once every 6 months, and it would do blood work on them. And what came out of that was that amongst this population in the Downtown Eastside of Vancouver, severely addicted, estimated between 3,000 and 5,000 people. Little break there. Anytime you're estimating and the variance is 2,000 people, you know how much guesswork is going on. What I want to say out of that is that we know next to nothing about the problems of our inner cities, right? And that goes for all cities, and that goes for the powers that be. So information gathering is incredibly important. And what came out of that? A lot of things came out of that. One of the biggest things that came out of that was that the HIV seroconversion rate amongst this population was between 20 and 30%. What does that mean? I don't know. What it's comparable to is Botswana in their AIDS crisis in the 1980s. These are some of the highest levels in North America. Bar none, they're the highest levels in North America. Wow, what's going on with that? In Vancouver, we have an incredibly robust public healthcare infrastructure, right? And yet there's a population, 3,000 to 5,000, in this densely clustered area that is so marginalized that they cannot access any of that healthcare infrastructure. It makes this, it's graspable why Botswana would have such high HIV rates, because their healthcare infrastructure was in its infancy and really trying to keep pace, and it was quite skeletal. That is not the case in Vancouver. Again, we have a very robust healthcare infrastructure, and yet that robust healthcare infrastructure that we're also proud of, public healthcare in Canada, is doing nothing to reach this clientele. So not only is HIV seroconversion rates going through the roof, but hepatitis C was at what they euphemistically called saturation levels. That's out of that report. That means that if this entire room are drug users in the Downtown Eastside, maybe those 2 tables don't have hepatitis C. Soft tissue infections. Absolutely rampant. Abscesses, right? They're not just sort of pimples and unsightly things. When you get them, and people are getting them like crazy because it's so unhygienic down there, they don't just go anywhere on their own. You don't get them treated, you don't get antibiotics, you don't get any attention to them. Often they travel, and what do they become? They become cellulitis, they become osteomyelitis, they become endocarditis. They have all these incredibly terrible outcomes, and we're seeing that more and more as we go through the 1990s. So you have essentially, in the middle of first world healthcare infrastructure, you have people who are effectively marginalized to the third world. Now, you think about what people's lives are like, or you hear from them what it's like, and generally, almost exclusively, the people that use Insight, the severely addicted people, are coming from backgrounds of severe trauma, often generational poverty as well. Often they have been unstably housed or chronically unhoused for most of their lives. Many of them suffered sexual abuse or violent abuse or serial abandonment and things like that while they were growing up. So it's a deeply traumatized population. And what I find to be my experience, is what is happening in the Downtown Eastside is that people are primarily injecting pain relief. The old idea that people are getting high just makes no sense in the Downtown Eastside. People are doing everything that they can to, in a sense, it's a misguided attempt that Gabor goes into a bit around seeking some safety, actually, from their lives, and it turns into its own absolute disaster. But again, people seeking pain relief is going on like crazy, compulsively, whether that is opiates like heroin, morphine, Dilaudid, or local anesthetics like cocaine. The use is absolutely rampant. The morbidities and the mortalities are just spiking as we get into the late 1990s. And the issue becomes, how do we end up connecting these people with healthcare, which they so desperately need more than any other population, apparently, in Canada? And that is a process that was really difficult and required an extraordinary and varied amount of advocacy. We have healthcare authorities in Vancouver. They oversee things like hospitals and clinics, and they fund all healthcare ventures in that area through the provincial government. Now, the healthcare authority at the time in Vancouver said, these people in this area can't get to the hospital and they can't get to the clinics. Well, we can't move the hospitals very easily, but let's move the clinics into the Downtown Eastside. And if we were to go on a walking tour of the Downtown Eastside, we could walk by about 5 or 6 clinics quite easily without straining ourselves too much. They are pretty much buttressing the area. And this was looked at as a hopeful solution for people not being able to access healthcare. But it actually wasn't a very good solution. And why was that? And it's because in our healthcare system and in any healthcare system, it feels like it's, for many of us, maybe it's not full of barriers in terms of accessing it and negotiating it. But for people who are poor, marginalized, have mental health issues, there are nothing but barriers in terms of accessing this healthcare. And to illustrate that, I think about the time when I had to take my friend Jay to the Pender Clinic. Now, Jay is a very tall and very daunting resident of the Downtown Eastside, frequently homeless, looks quite a bit like a Viking with a whole bunch of layers of clothing on him, and he actually has some serious mental health issues. He often communicates in quite a strident and striking way, and often he's really agitated and amped, and he's got these piercing blue eyes, and he's pretty daunting if you don't know him. What Jay was amped about one morning when I saw him was a large swelling on his leg, and he's limping, and he's not moving well, and he's upset about this, and this isn't going anywhere, and he's agitated, and he doesn't know what to do around this. So we talk, and it's like, Jay, why don't we walk over to the nearest clinic, and we'll get you some antibiotics and take it from there. So we walk over to the clinic, and as we get to the front of the clinic, Jay is seeing something that he doesn't want to, makes him not want to go any further. And that is the private security guard that's maintaining security at the front of the clinic. This guy's a nice guy. I know him, but he's wearing the very same uniforms as one of the many security guards in the area who treat addicts like absolute shit. They're power trippy, they're very adversarial, they're very physical, maybe when they don't need to be, so they have a really terrible relationship with the users of the Downtown Eastside. So the idea that a person wearing the same uniform is actually the first person to greet you when you go to a clinic is not exactly rolling out the welcome mat for somebody in that situation. Now, if one of you is escorting him there, you talk your way through it, right? It's not going to be a problem, buddy. He's a really nice guy. I know him. You do what you can, and you go through that. Without that advocacy, there's a strong chance that visit's going to stop right there. So that's the first and most apparent barrier to accessing healthcare in the Downtown East Side. You get past that, and then you get to a very crowded front desk, and you have to do a bureaucratic intake. And this is not a very easy thing for a lot of people in the Downtown East Side to negotiate. It's not easy to negotiate when you're agitated. It's not easy to negotiate maybe if you're on drugs. Not easy to negotiate if you haven't slept for 5 or 6 days because you're homeless and maybe you're using crystal meth to stay up, all those things. And it's not easy to negotiate if you have to fill out paperwork and you can't read or write. And literacy issues are incredibly prevalent in the Downtown East Side. Not only that, but the clinic that we were at that time, it's a very busy front desk. There's lots of people around. You need to say what you want really quickly. You need to know what you're talking about. And as well, there's a little list there saying that if you get upset or you swear or anything like that, you'll be chucked out of the place by the security guard like that. So that's the second barrier. And in a lot of cases, many people in the Downtown East Side who have had really, really shitty bureaucratic experiences. I don't know how many good bureaucratic experiences there are, but things like welfare intake meetings. If you ever have a chance to sit in on a welfare intake meeting, it'll make your skin crawl. It's so top down. It's quite brutal. At least I found them to be brutal. And having gone through that, a lot of people aren't anxious. They don't feel a lot of agency about negotiating bureaucracy. So that's the second barrier. And what I found to be the third barrier, what he found to be the third barrier, was after that, when we went and sat down to wait an hour for the doctor in a very crowded waiting room, and Jay hadn't bathed in a month because he was unhoused for most of that time, and he's getting really cranked and he's morbidly self-conscious about being in this waiting room full of people. And he starts turning around and sort of polling the room. Can you smell me from where you are? Can you smell me? I know you can smell me. Can you smell me up there? And it's kind of touching. It's kind of like weird, and people are getting freaked out. And as he keeps doing this, and he's getting more and more amped, well, that security guard is definitely getting interested in us now. And after about 3 minutes, that is 1/20th of the wait time, there was an easy consensus in the room that we maybe needed to get out of there. The whole room was tired of us. Jay was really upset by that time. The security guard's interested in us. Maybe don't want that. So with an advocate there, what do? You go out and you get a cup of coffee at McDonald's and you kill an hour and you go back for that meeting. But if you don't have an advocate in that case, you're not going to make it through that wait time if you haven't bathed, if you're really, really self-conscious, and of course it's very humiliating to be in that spot. So that's a third barrier, and wait times almost in any healthcare system, an hour's not a bad wait time to see a doctor. You try doing a hospital intake, you'll have multiples of that going on. So those are three barriers with just a very average trip to a clinic to try and access some antibiotics. And I haven't even gotten to the doctor yet, and the doctor's suppositions about drug seeking and things like that. So what you find out is you brought the clinic right down to the Downtown East Side. You brought it down to within a block of where it needs to be, but you haven't done anything really to make it accessible to the most vulnerable people. And this became a real issue around healthcare in the Downtown East Side. And when the idea of a supervised injection site as being a necessary interface into this problem came up, one of the big issues that came up around it is, well, if you build it, how are you going to make it accessible, right? Now, I work for the same group that Gabor works for, actually, in the realm of the Hungry Ghosts. It's called the Portland Hotel Society. And they are a socially active nonprofit group that does a variety of things in the area. They have housing for what we'll euphemistically call the hardest to house people, housing with a no eviction policy. The philosophy is to move into some of these decrepit SROs, renovate them up to some sort of livability, see if we can provide housing for people who are really the most marginalized people, and then see if we can attach services to the hotel, embed medical services, have nurses and doctors visit the clinic. That's how Gabor got his start. So that's one of the things that they do, and they were very much players in how this supervised injection site was going to look and how it was going to operate. And right now, as we sit, and for the last 10 years, they have co-managed this supervised injection site along with Vancouver Coastal Health. So it's the local healthcare authority, which is an arm of the government, partnering up with a sort of socially active non-profit group to run a project. And that's a really interesting philosophy, but the idea of the Portland Hotel Society is sort of a lot closer to the ground in the Downtown Eastside than Vancouver Coastal Health Authority is. So they recognized, Vancouver Coastal Health did, that we needed some sort of bridge between the medical system as it stands and the community. And it was very apparent that this community wanted to be taken seriously and included in those discussions, because when we talked about the advocacy, when we look back on the advocacy for the site and what made that happen, the community activism, the activism of the people who were affected, of the drug users in the area, was exceptional. They were exceptionally motivated, and they linked up with various nonprofits and all kinds of groups in order to provide advocacy for harm reduction in general and a safe injection site in particular. And this next slide shows all the variety, the whole matrix of sort of advocacy and support that gathered together to make this project happen. So we've got VANDU at the bottom, which is the Vancouver Area Network of Drug Users. We have officers from the Vancouver Police Department, which incidentally is located, or was located at that time, right in the heart of Downtown Eastside, probably a half a block away from Insite, and about a half a block away from the largest open-air drug market in the city. That led a lot of members of the VPD to understand that they were not going to arrest their way out of this problem, so they became sympathetic to other approaches. Community activists were important, a lot of them from VANDU, from Grief to Action. Grief to Action, that was another really powerful advocacy group. And they were a group of parents of addicted children or addicted adult children who were living in the Downtown East Side. And their advocacy was really important because we all get numb to seeing someone from the area who looks like a stereotypical drug user talking to the camera. When you're talking to some parents around that and they're advocating for supervised injection sites and harm reduction, that reads completely differently. So that was really important. Healthcare workers, nurses, very important. Academics were really important. And we actually had some politicians who did some very, very bold things in terms of supporting the site. So the struggle to open the site ended up being a struggle to sort of move past some very dominant but not very well thought out opinions around services for drug users. And they are that the primary one being that we need to make drug users more uncomfortable in order to encourage them to stop using drugs. And that if we apply any services to them or provide any services, we're saying it's okay to use and that it's not harmful to use, and that's a really negative thing. That was a dominant ideology in Vancouver in the early 90s that it took this combined effort to sort of work past. Other things are that services for drug users attract drug users, right? And this is going to turn into a honeypot effect. All of these things had to be strenuously debated, and what went on essentially during the 1990s in Vancouver is you have this group of activists basically taking the issue of serious addiction and pulling it out of the shadows and dragging it into the light. And that's what happens around any issue where we have any significant social protest, or social progress rather. Gay rights issues, women's issues, mental health issues, all kinds of healthcare issues, mental health issues, all of these things had to be dragged out into the public sphere. And that's the job of advocacy. That's the job of, I'm going the wrong way. Shit. I'm losing it here, buddy. Oh well, enough of the slides, I guess. But the job of advocacy is to drag this into the public sphere and then to ask our public officials to be accountable around this, right? And what's happening is, in terms of dealing with bureaucrats, what's happening through this process is, let's say you are a politician, a bureaucrat. Maybe you're the mayor, maybe you are a city councilor. At the beginning of the 1990s, it's very risky, even though you might support a supervised injection site, it's very risky to support one for you politically, isn't it? And bureaucracy is all about risk management if you're a professional bureaucrat. So there's all this risk on one side. What advocacy wants to do is to start piling up risk on the other side of that equation. And that happened all through the 1990s, to the point where we had a mayoral race in 2001 in Vancouver that was largely determined on whether or not the victor was largely determined on their support of the supervised injection site. And that mayor, Larry Campbell, was actually an ex-chief coroner, so he had added credibility around that. Before that, we had a very socially conservative mayor named Philip Owen, and he did an about-face and very courageously and radically began supporting not only harm reduction, but a supervised injection site in the Downtown Eastside. And it led to him actually being ousted by his party, which was very conservative that way. So politicians were very important as well. And what that meant was by the time we were at 2001, it was decided that we were going to have one of these sites. And then the questions came up, what is this site going to look like and how's it going to function? And that is where the partnership between Vancouver Coastal Health and the Portland Hotel Society becomes really important. So I'm going to skip forward a little bit and talk about how the site operates now and unpack some of those things around lowering barriers. The site is still functioning 10 years later. It is probably it's definitely the busiest supervised injection site in the world, and there are close to 100 supervised injection sites worldwide. It's the only one in North America. We do an average of 1,200 visits per day for a variety of purposes. It's incredibly busy. There are 8 staff on it at any given time, so it's kind of a handful. Now you think 8 staff and 1,200 visits. 1,200 visits is, in a way, it shows the amount of addiction in the area, but it also is a sign of success because it's very important to get people to use this site if they're intravenous drug users. And why? Well, why? Because of the mandate. The number one mandate for Insite is for people to, rather than using in the alleys, to come in and use under nursing supervision. And that is to prevent overdose deaths, to bring down that tide that was at an all-time high in 1997 when we had 412 people dying from ODs that year. And when you're using inside a single-room occupancy with nobody around, when you're using behind a dumpster, those are the situations that people die in. Other things happen to try and stem that tide. We had a sort of a Good Samaritan rule where it was agreed that when people called the ambulance for overdoses, we were no longer going to send the VPD with them. That was very important. You guys actually just got a Good Samaritan rule to this effect that people calling the ambulance for ODs will not be prosecuted. I think it's currently in Washington, which is cool. But the number one mandate at Insite is to prevent overdose deaths, and that's the rock bottom principle of the place. Now, the second part of the mandate is trying to prevent the spread of disease. And if you were to walk into Insite, and I'm really sorry that I can't get this. David, can you help me get this next slide up? Because it's the injection room I'd like to... Oh, back. Here we go. I'll move forward. So if you were to walk into Insite, and I don't think you're going to be able to see it from here. Oh, and this slide isn't turning up. Shit. In the injection room, there are 12 bays where people can inject. And then there's a table where nurses can look at people and keep them under observation along with non-clinical staff. And then at the end of the room, which is a really interesting looking room that you can sort of see in David's first slide, there are 2 things called sinks and running water and soap. The health care that goes on in terms of disease prevention not only includes clean equipment and having a nurse be able to talk to you about maybe the best practices for injection, it's things as basic as being out of the elements, being in a warm environment, and having access to running water. So what we're trying to do is get people to access some basic first world services at Insite, and that's really, really crucial, because when you talk to people who are severely addicted in the Downtown Eastside about what it's like to be in withdrawals, what you will hear is that this word hopelessness, and panic are the most frequently mentioned words. So when you're in severe withdrawals, it is a crisis, and it's a crisis of the first order right in front of you. And it is everything you can do, you're doing everything you can to solve this crisis. And that means if you're a guy, you're going to be binning from sun up to sundown, going through garbage cans looking for recyclables. If you're a woman, there's a strong chance that you're going to be doing sex trade work to support your habit. And sex trade work is the most poorly remunerated and potentially lethal job in any society. We actually had a serial killer in Vancouver named Robert Pickton who killed about between 35 and 40 prostitutes from the Downtown Eastside area. One of the reasons he preyed on them was because nobody gave a shit and nobody missed them when they were missing. So, you have a person who's extremely desperate, and here we have the injection room. You have someone who's extremely desperate, looking to get unsick. You have to do all this degrading labor in order to get $5 to $10. Then you go and you try and score on the corner of Main and Hastings, just near the police department, and you manage to score without getting beaten up or bunked or busted. And by this point in time, I guarantee you, your body is talking to you like crazy. It's saying, I need to get unsick now. Not about getting high, it's about getting unsick. So I've got this dope, and I've got maybe a rig that I've got somewhere. Now I got to get this in me. Now, even at the height of the public disorder, most people are not going to try and find a vein out on the street in the corner of Main and Hastings. So what do? You go into an alley, probably, right? And many people are using in the alleys in the Downtown Eastside. Why? Because it's hidden. You're not going to get busted. And when you get into the alley, what you're going to do is you're probably going to crouch behind a dumpster because you're sort of hidden that way. And you can crouch down there and nobody's going to see you. No police are going to see you, no other users, whatever. What you're doing in that case is you are getting yourself into one of the most dangerous and definitely one of the most unhygienic circumstances imaginable, because it's a significantly homeless area. There's lots of homeless people around there, and the areas behind dumpsters are basically the public toilets for people to relieve themselves in. So if you think about performing what is essentially a medical procedure while you're standing in a toilet, it doesn't make an awful lot of sense. And you are doing this under very rushed circumstances, and you're doing it out in the elements, and you're jonesing like crazy, and you got your sleeve up out in the rain, and you're trying to find a vein, and you're doing what we would call worst injection practices. You are not filtering your drugs, you're not rotating your veins, you're not using a tourniquet, you're not washing your hands at the injection site. You are doing what's called a shake and bake. And you see that happen all the time in the alleys. It's rushed, it's incredibly unhygienic, you're shaking up your dope, holding a torch under it, and then you see people who don't have a clue what they're doing, joysticking, trying to find veins, just hoping that they flag. Very, very common, even on people who've been injecting for over 10 years, to have no real knowledge about how to locate veins, which leads to dilapidated vein structures, collapsed veins, and lots more problems trying to actually inject. Now, the liabilities in this case, if you want to stack them up, are A, if you overdose. You find a vein, you inject it, and you overdose, you are in the worst position because you're hidden. And so many people were fished out of behind dumpsters in the alleys in the middle of the night that it was a joke in Vancouver. The second thing that happens is, A, your chances of getting a soft tissue infection are incredibly high. 90% of the soft tissue infections that we see in Vancouver are starting on bacteria on the substratum of people's hands, right? So that becomes a very, very easy avenue to contract a soft tissue infection. The other thing is that if I am walking down the alley and I see you and you're using there and I'm so dope sick I can't believe it, that helplessness or hopelessness and panic means that I don't give a shit about HIV or hepatitis C. I just need some dope, so if we could share, that would be just fine. So the possibilities for sharing in an unstructured environment, even with the amount of clean equipment that we now have available, are quite high. Last thing is, if you think, what the hell am I doing out here in the alley with my shirt off trying to find a vein in the middle of winter? What else can I do? How can I get help? There's nobody who's going to hear you in the alley. So the basics around Insight are trying to get people to access nursing supervision, hygiene, simply being out of the elements. And the third part of our mandate, after trying to prevent the spread of disease, is to build trust and relationships with this population. A great deal of the people who are traumatized and marginalized in the downtown east side of Vancouver have been traumatized and marginalized by the ways we've tried to help them in the past. The residential school system, the foster care system, variety of systems haven't served people well. And now we're seeing some of the fruits of that. And what's more, now when we're asking to help people, they're a little bit cautious. They're like, you know, I barely recovered from the last time you guys tried to help me. Maybe no thanks. So it's a really important thing at Insight for us to build trust with people. And I'll unpack how that happens as quickly as I can because time's running on here. But when we build trust with people, what we find is we have a much easier time advocating for housing, advocating for detox, advocating for things like methadone, for dental service, for anything that they need. So that's the fourth goal of the site, to take people who really don't go into anywhere indoors outside of Insight and try and leverage them, if we can, into higher threshold services. You don't build that, or you don't do that unless you're building trust with people. So if you were to come in and sign up at Insight, if any of you were to come in, the first thing that would strike us is that you look too healthy and out of the area. So we'd have a bit of a diligence process around that between you, me, and a nurse. But if you were someone from the area and it was apparent that you needed to use this service, and often we see people showing up with visible track marks and things like that, what I would want to do, and what we do there, is rather than having them sign up at a front desk, we'll have someone go and talk to them in person about the site, about what the site does, establish their need for the site, and to talk a little bit about the ground rules for the site. And one of the things we want to do in that conversation, which significantly does not involve paperwork or the showing of ID, what we want to do in that conversation is we want to get some buy-in from people, and we want to say this site is designed specifically for you. You're not an outlier here. And what's more, we actually need your help to run this site, meaning we have 8 staff and about 1,200 people a day who visit the place. So what we really need out of you to help keep this site running for all of you is as much tolerance as you can muster for your fellow drug users, and a stated goal to do the best you can keeping the street out on the street. And there's some other rules that I unpack, but the significance of unpacking rules, like you can't inject anywhere other than the injection room, is rather than posting a list of rules on the wall, it's very important for staff to deal with rules and things like that. It's very important for staff to explain the rules and why it's important to follow them, and why doing that helps keep the site open. It's actually much more effective than the very dull thing that people do, which is posting the list of do's and don'ts on the wall, and it starts relationships and gives people a sense of buy-in. So that's an important thing about the sign-up process in terms of lowering barriers. We do not have an active security presence as well at Insite. Our security policy is relationship building. Once we know each other,